Hi, I'm Perry Atkinson, General Manager here at theDove. Hey, check out our other videos and check out our website at thedove.us. Well, welcome to Focus Today. I'm your host, Perry Atkinson. Always a delight to have Dr. Joel Klein in the studio with us today. He's with Ventana Wellness. And by the way, if you want to ask any questions, you're welcome to join us. The phone number is 541-776-5368. Or if you're outside the immediate listening and viewing area of theDove, you can call us toll free, 800-373-5368. Ask the doc. And here he is. Dr. Klein, how you doing, bud?
Good. Good morning.
Yeah, good morning to you. Good to see you. All right, cancer screening. Why did you pick this?
Well, because I think people need to be educated that it's not what it's been cracked up to be. There are some questions about issues. Particularly, the ones I wanted to address today are prostate and breast cancer screening.
Okay.
And that, you know, assumptions that we've been making actually for the past 150 years about the way cancer spreads. You know, it was thought in the beginning and has been thought, and some cancers still work this way, that it grows to a certain size before it starts to spread, because it has to grow gradually in the same place till it breaks through a blood vessel or a lymph vessel and then starts to spread through the body. And it turns out that that assumption is not necessarily true, and with that it really calls into question the results that we're getting with cancer screening.
Whoa. All right, so what is cancer screening?
So we're talking, you know, the things I want to talk about big today, mammography and routine testing of the PSA, the prostate-specific antigen for prostate cancer. So again, the whole notion would be, if it takes a while for a tumor to grow to a certain size before it spreads, the whole notion was, wow, if we can catch it before it breaks through, we can prevent it spreading. Okay. And it turns out that it depends on the tumor. And what we're learning about certain tumors are certain genetic mutations in tumors that make them particularly bad actors. And if you have a tumor with that genetic mutation, then what's happening, I think particularly in prostate and breast, is that by the time it even shows up on the screening exams, it's already broken out. It's an aggressive tumor that has already started to spread, so that the screening exams, and this is what we're seeing when you really analyze the data on how well we're doing with these cancers, are not what they've been cracked up to be for all this time. And unfortunately, I know I'm always the fly in the ointment, because I feel like I'm the only one getting this information out. Most of what people are hearing is coming from agencies and people who are promoting. They're not hearing the other side, and I feel obligated to let people know it's not quite that cut and dried of, oh, you get the screening test, it tells you if they have cancer, and you get it, and you're, you know, and they cure it early. It turns out that's not the case when we really look at the information.
This is a big topic, because I think you and I have talked off air and elsewhere that I just feel cancer is epidemic, but we're afraid to call it that.
Right. Although some people are, but yes, sure it is. It's the second leading cause of death in the United States.
It's epidemic, and we're not
estimated to be the first will overtake heart disease, I think, in time.
And I guess it's impossible to say how many types of cancers. There's just multiple.
As many different types of tissues there are in the body, because cancer is multiple different things. Well, any tissue, can have a different cancer and have different qualities based on what organ, what tissue that cancer came from.
Because you have to ask yourself, where was cancer 50 years ago?
Well, this is interesting, because I'll tell you about where it was 100, maybe 150 years ago. Right. From what we know in Victorian England, and this is not from bad data, what we've learned is that this was the heyday of anatomical pathology, when doctors were doing 2 to 3 autopsies a week. That cancer was relatively rare as a cause of death, maybe 10%. And they thought that maybe that group of cancers were the genetic cancers. What we're really learning of all this gene work that's been done in cancer and the genetics, these cancer genes that they're describing, like people may be familiar with the BRCA gene that has to do with breast and ovarian cancer, or there's one that was discovered for colon, account for at most 10% of those cancers. So somebody said, well, it's not in my family. Okay, well that gets rid of the 10%, but 90% of people with that cancer don't have a genetic issue for it. Now, what is that due to? Well, all kinds of factors. Our diet and our environmental exposures are probably the main factors in that.
All right, so what I hear you saying, Joel, is that the screening works, but it may be too late to prevent.
Well, the whole point
is that right?
Well, yeah, well, the whole point is we want to prevent death from cancer.
Right.
By getting it, theoretically catching it early, we can prevent it from getting when it's been more advanced. It turns out for the best success in this area has been cervical cancer with pap smears. That is an unqualified success, undoubtedly. Colon cancer probably does adhere to that old model where it grows to a certain size before it breaks through. So colon cancer is one, so far it looks like, that if we can prevent it. The problem has been the screening tests. Not everybody can get a colonoscopy. But with prostate cancer, number one, most men will die with it if they have it, not from it. And the question is, who are these men, and they tend to be younger, who have an aggressive tumor that is going to break out and kill them? And by the time it shows up, even if you have one of those tumors, the PSA probably a lot of the time may not pick it up in time. So what has happened is that the United States Preventative Services Task Force, which is an independent board of preventive medicine specialists, these are not cancer specialists, these are preventative medicine specialists, recently came out against routine prostate cancer screening in asymptomatic. So you come in, you're here for a physical, and we just routinely do the test. Because it really hasn't worked in decreasing deaths that much. And so what has happened was, with all the treatment, what they say, for every life you save, you will make 30 or 40 men impotent or incontinent or have permanent side effects from the cancer treatment. Whether it's prostatectomy, radiation. Now they're doing a better job with these, radioactive seeds that they put in, localizing the radiation, but there's still long-term complications from the treatment, and we're not making that huge of a difference in it. So for years they said there was actually evidence that you shouldn't do it. They finally came out and said, we do not recommend this as a routine part of health screening. And of course that's quite controversial.
All right. Because the next obvious question, and I don't want to answer it right yet, what's the alternative? But come back to prostate screening. So you're saying, does PSA go up and down? I mean, just naturally?
It tends to increase with age over time. So, of course, as men get prostate enlargement, we can talk about what causes prostate enlargement, which has to do with our friend inflammation, hormonal issues, some of these other metabolism issues that have to do with diet. But as you get prostate enlargement, yes, the PSA will naturally go up. It can go up and down in infection and inflammation.
Because I know some men who had a high PSA. Right. They panicked, went through they actually had it removed, and they lived to regret it. And I'm thinking, well, wait a minute, can't you see if it's going to stay up or come back down before? Well,
it's not a question of what the number is. It's what does the number signify? The question is, do you have cancer?
Yeah.
So I would assume that these gentlemen had cancer, but the question is, there are grades of cancer. And without getting too technical, they can actually, when they do the biopsies, they can look at the cells and see to some degree how aggressive the tumor is, or something called a Gleason score. And now with a lot of them with this Gleason score, let's say it's 6, found that doing nothing does the same as doing something.
All right, so in the meantime, breast cancer, women can go and have the x-ray done, the mammogram done.
Right.
You might find a lump, and you're saying if it's that size, it's already a problem.
No, if you have a tumor that's got a bad mutation in it, maybe is already broken out.
Okay.
Here's the issue with mammography. When they really looked at it dispassionately, the few people who've been successful in doing this, because it's a political issue as well as others, it's probably only really benefiting women in their 60s. They came out years ago saying they didn't think we should do it with women in their 40s because you have a lot of false positives in women who are prior to menopause because the breast tissue is denser. So you wind up with a lot of biopsies and a lot of things, and people are supposed to feel better because, oh, it turned out you didn't have cancer. Well, if we weren't doing all of this, it never would have come up in the first place. So women in their 40s, it's more difficult. Of course, those are the ones, if they do get cancer, it's a more aggressive tumor. That's a problem. We don't have great screening for these things at this point. And again, those more aggressive tumors may have already started to break out by the time you even see them on exams. The thing, one argument with the mammography issue is that if it were really doing what we thought it was supposed to do, we should be seeing less cases of advanced disease because we're catching them early. We're not. We're not seeing less cases of advanced cancer. We're seeing improvement in survival that most experts feel is likely due to improvements in the treatment. But the screening has not really been what has made the difference in that.
All right, before we take a break, does blood tests show cancer?
No. Okay. Very rarely. Blood tests will show, there are markers that we use for tumors, but they're not felt to be, except for the PSA. Right. But even then, all these things are markers, and then you have to look at, all right, what does this marker mean? And no other really blood tests other than the PSA that has been used are felt to be good enough where you can indicate. There's something that's very popular out there, I forget what it is, but it's an alternative test that people will get, and then it's like, oh, it's positive. Well, now what do we do? Somewhere in your body there might be cancer. We can't put you in a whole body MRI and do surgery because this one blood test was positive. So what do you do with that? So that's a tricky issue.
All right, we're going to take a break. When we come back, Dr. Joel Klein's with us, and I'm going to have him give the alternative to what he's talking about here. And if you want to join us, the phone number is 541-776-5368 or toll free 800-373-5368. We'll be right back. Okay, we're back with Dr. Joel Klein today here from Ventana Wellness. And by the way, it's ventanawellness.com, and it's an incredible resource for you on a lot of issues. Dr. Klein is the leading physician there, and you got all kinds of specialties, don't you?
Yeah,
dermatology
and pain, and especially you do have a great chronic pain clinic, Dr.
And he does the
Osborne.
prolotherapy thing there?
He does prolotherapy with this newer thing called PRP, platelet-rich plasma, for chronic pain, musculoskeletal issues, yeah.
Not to mention the fact that well known for hormonal balances and things like that.
Right,
with
that's
Jackson.
kind of a forte.
All right, so Dr. Joel Klein, Ventana Wellness. If you don't have a good physician, there's one right there. All right, we're talking about cancer screening, and you're basically saying, okay, it does detect, it's not that reliable, so what's the alternative?
Well, I'm saying understand the limitations. Well, there isn't a good alternative right now. Early detection is, for most illnesses, for most cancers, is not a great option. It's one we have. I want people to understand the limitations of it, that it's not a be-all and end-all. In fact, I remember this was, in the late 90s, because I was having this discussion with a patient, and he thought I was crazy. And he went online, and he came back, and I was amazed. He even found a urology website in Chicago, and they even said on the website, if your interest is in finding and treating prostate cancer, period, get the test. If your interest is in preserving quality of life, don't get the test. Most people I know would rather, if they're going to live shorter, better, rather than live longer and be miserable, but that's an individual decision. But that was even a urology website. Wow. So the bottom line still comes down to, obviously it's a huge problem, and what we talk about, diet, stress, environmental toxins. We really need to look at what's happening with our environment, with our water, with our air, certainly our diets. They think that the Victorian English that I was talking about earlier didn't get as much cancer because they ate all of this produce. They ate way more than we did because they were much more active. You didn't turn on a light switch, you stoked the fire. They were doing more, they were burning more calories, but most of those calories were people who could afford it. Obviously, the poor were living in their sewage and they were dying early of communicable diseases and whatever, but those who could afford it were living longer. In fact, the data is that they lived as long or longer than we do now. Wow. It is a fallacy that human beings have never lived as long. In the late 1800s, they were, if you lived past the age of 5. Now, there was huge infant mortality, but if you made it past that. So it's diet, lifestyle issues. Understand these screening tests are somewhat useful, but not a fallback. Well, I'll just, I'll treat my body the way I want, and then I'll just get these tests to see if they can get the cancer early, which is clearly a game of Russian roulette.
All right, so there for a while, and it may still be, that there was this trend to have a full body MRI just to see where you are. Does that do anything?
No. No. What are we going to do with that? And send people to surgery? No. Number one, prohibitively expensive. Number two, if somebody wants to pay for it, and then, we find something, and then you go through the whole medical workup, and you do this and that, and what do you find? Even that's not going to detect microscopic issues. Our whole thing of screening, I was just reading in the New York Times yesterday, had to do with this columnist's daughter's pregnancy, which was a lot different than hers. Says they're now treating it like a 9-month illness that ends in birth. I mean, she was screened up and down, and all of these false scares. Oh, well, the babies might have short bone syndrome from ultrasound, or it's not growing enough, this and that. And there's only going to be 5 pounds, so they wound up and it was breech. So they did a 2-week early cesarean section. Baby weighs 6 pounds, absolutely nothing wrong with it, but had all of this medical testing done. And what's being accomplished? Are those things really making a difference? You have to look at what is going to be done with the results. You don't just do a test to do it. What are you going to do with the answers if they're positive? And I think we're over-medicalizing because, quite frankly, yes, there's a feeling of, we're doing something, but there's also a financial incentive to all these tests. Somebody made money out of all those ultrasounds and all those tests, so there's a financial incentive to doing more, and we feel better that we're doing more. But the whole question I want to raise is, are we really accomplishing something? And that's what always has to be asked.
You're saying no.
No, I'm saying sometimes no. I'm not saying always no, but I'm saying the information is not as cut and dried in many areas as it has been, and you really need to start, asking questions. What's being accomplished, and what are we going to do with that information?
Joe, I know as a physician, you obviously see it more than I do, but there are those where you catch it early, it's treated, and you beat it.
Right.
I've had very close friends that were basically stage 4, which is, I guess...
That's widely metastatic.
Okay. Beat it.
Yeah.
Okay. But then there are those who all of a sudden, no feeling, no indication, no nothing that they got it. And when they finally have a problem, maybe pain or something, they look in there, they're just full of it. Mm-hmm. There's something about cancer that's mysterious. Very
much so. In fact, a nutritionist, a very well-known and good nutritionist that I knew, died at 49 of metastatic colon cancer that showed up in just that way.
Okay. A lot of treatments for cancer. You have radiation, you have chemotherapy, you have surgery.
That's pretty much what you have in medical therapy. Right.
Okay. Pro-antibiotics or probiotics, are they being used?
Not that much. By that time, probiotics can be helpful, but I think that's putting out a house fire with a squirt gun. Okay. You really need, once you're dealing with cancer, you need an integrative approach, and some people are really looking into this. There's a clinic in Ashland, the Mederi Center. Donnie Yance there has been doing great work for years that's finally being studied on integrative approach to cancer patients. Choosing the chemotherapy based on the genetic mutation driving the tumor, not just where the tumor is coming from, using exhaustive herbal regimens that he's found, and there's research that shows the herbs actually help keep the tumor sensitive longer to the chemo. So there is a right way to be doing this. They're in the process of actually doing a study with it, but the chief of oncology at Johns Hopkins was so impressed with his results, he invited him to speak at Hopkins. So it's getting some attention.
Okay. All right, let me see if I can squeeze this in. If we can get Frank, are you there?
Yes, I am.
Your thoughts?
Dr. Klein, I have BPH, and my PSA has usually been 1 or 1.5. Went to the urologist, found that I have a nodule, and he wants to biopsy it right away. And I'm concerned about that because what I've seen with biopsies with needle tracking and sepsis and infection, I'm concerned and afraid to get the biopsy, you know, and if I did have cancer, I don't know if I'd even want to get treatment for it with all the problems I've seen. They all come with their own specific problems, but incontinence and things like that. So I'm in a quandary as to what to do.
Well, you raise all the important issues, and I don't know enough to give you advice, obviously, in this direction. That's exactly it. There are complications to the biopsy. What are you going to do with that information if it is cancer? And can we guarantee it's not? No. With a lower PSA, it's less likely, but that doesn't guarantee anything. And the question is, you know, I don't know, I need to know more about you in terms of age and these other things where, you know, older men are going to have indolent tumors. Younger men, you know, it may not be a problem. And that's the whole point, is that what you really have to look at, and may get some opinions even from some alternative people who are skilled at cancer treatment, like these folks in Ashland would be the ones that I would recommend, to see, you know, what should be done about it, because there's all kinds of information that needs to be put together rather than a leap towards, biopsy treatment and the like.
All right, thank you.
Okay, thanks.
What about just a good old cleansing? Because, you know, the other thing is, you hear people that go through so much chemo, they're so, their immune system is so beat up at the end.
Right, and their gastrointestinal tracts. I had a new patient last week just with that, with, you know, still probably years, you know, a little while after the chemo, and we have to rehabilitate the GI tract from all of that, right? So it's done the right way. I am not a trained naturopath. I have a lot that I do with that. There's a right way to do these things. Usually in that kind of situation, you don't want to do aggressive detoxes at first. You want to help repair and build up the body, because detox takes energy. And if you try to detox somebody who's already depleted, you're actually a lot of times make them sicker and give them the detox crisis that some people say is a good thing, but the people that I train with says, no, you don't do that to people. So there's a right way to do it, to try to build people up and then provide all the raw materials so the body can detox itself. There are people that do that. They're probably much more skilled in it than I, but I don't do like aggressive cleanses other than putting good stuff in.
Yeah, I just don't know what I'd do. I mean, if I was diagnosed today, I've always thought surgery, once you give outside air to cancer, it's like gas on a fire. Actually,
it may not be the air as much as when you do surgery, by naturally all the body tissues that are wounded put out all these growth factors that are what stimulate the tumors. Why you may hear these stories of somebody had surgery and then, you know, 2 months later they were riddled with tumor, because there are these things called epidermal growth factor and a number of different factors that are released in the act of surgery, that if that tumor has the right mutations and that tumor is sensitive to those factors, it can cause it to literally explode.
Loaded question. Does chemo work?
Absolutely. Absolutely, it works. I think I think it can be applied much more intelligently than what they're doing, and it's not just me. There was even a specialist at Sloan Kettering in New York, in an article in Newsweek magazine a few years ago, who said they're still doing what he calls big dumb studies. They're not tailoring the chemo to the genetic mutations driving the tumor, which will determine what chemo they respond to. They're still doing, oh, you got breast, you get this, you get colon, you get this, you got ovary, you get that, rather than looking at the actual tumor. This is what, like I say, the folks in Ashland and some other folks are doing to more intelligently use the chemo. But there's times, I can tell you people certainly whose lives were saved.
What about direct application? I mean, you go to the tumor instead of the whole body.
To figure out a delivery system. And the problem is tumors by their nature are outgrowing their blood supply, so the middle of the tumor a lot of times is not going to get any blood. How do you get it in there? So I don't know enough about that to be able to tell you, but I do know that there are more intelligent ways of applying what we know from an integrative standpoint, supporting the body, using natural things that will actually keep the tumor more sensitive, and using the medical therapies themselves.
So I'm hearing you say, Dr. Klein, a key part to this is knowing your own metabolism, so to speak. I mean, you got to know.
Well, it's how well you've been taking care of yourself. I mean, if you've been smoking and eating an American diet for 40 years, don't expect miracles, and you're going to go to Europe and go diathermy treatments and do coffee enemas and do this and that. I would be kind of suspect that you're going to get somewhere with it. But so a lot of that has to do with how well have you taken care of it up to that point.
But cancer's no respecter of person.
we basically have
Or
to deal
age.
with it as it is,
Yeah.
and try to make the best intelligent decisions we can given the information that we're given.
Well, thank you. Let me just say to our viewers and listeners, if you want more on this, you can get a hold of Dr. Klein, VentanaWellness.com, or you can call and make an appointment with him. But VentanaWellness.com is a good resource. Well, thank you.
My pleasure as always.
I'm amazed that we don't call cancer epidemic in this country. I don't know why we haven't declared it.
We declared war on it 40 years ago.
Yeah.
You see how far we've gotten.
Not very far.
Yeah.
It's actually gotten worse.
Right.
Yeah. All right. All right. We'll be right back.